Hello everyone. So we've just learned how to do relatively straightforward annuloplasties using several techniques: flexible, semi-rigid, and rigid rings. Now let's embark on how to begin doing mitral valve repair. The most common pathology patients suffer is prolapse of the posterior leaflet, and that's likely P2, the central scallop. And there's two ways of addressing this in a very straightforward way. One is a triangular resection, and one is no resection, just using neocords. Building upon what we've just seen in annuloplasty, let's have a look at how we begin the process of doing robotic mitral valve repair.
Principles of mitral valve repair include analysis and exposure, and then stepwise repair. Let's take a look at the first case, which is a patient with posterior leaflet flail, relatively normal anterior leaflet and preserved ventricular function, with a focal area of P2 and relatively normal P1 and P3 segments. The valve is exposed and set up. For these cases, we try to limit the extent of resection if it's a focal pathology. And given this area, we will do a focal triangular resection. This starts by mobilizing the leaflet, cutting any secondary chordal attachments that otherwise may be limiting or restricting, and performing a decent-sized triangular resection. Note that this goes to supported chord groups as the margin on each side. This is 4/0 monofilament, known as cardionil, 10 centimeters in length, which is ideally suited for these types of repairs. Instead of running, I prefer a figure of 8 interrupted suture technique for each bite. And after the knot is tied, I use one of the tails to retract and use the dual blade as fingers to retract them anteriorly to help complete the repair. You'll see this again in other cases. A true-sized annuloplasty is then performed to complete the repair. And this is the very standard, typical P2 resection for the vast majority of patients. As you can see, there's an excellent depth of coaptation, likely 10 millimeters or more, and this is likely to be a very durable valve for the patient's lifespan with no stenosis. What happens when the disease is slightly more involved and perhaps more support is required? This is a 59-year-old gentleman presenting with severe symptomatic mitral insufficiency due to posterior leaflet flail, as well as more extensive myxomatous degeneration, perhaps, involving slightly more of P2. Cardioplegic arrest is delivered as usual, and the valve analyzed. In this case, I'm going to show these retraction sutures, which you may have seen in previous videos. It starts in the annulus with a braided stitch, tapping the posterior pericardium, and then to the edge of the pericardial shelf that we had created at the very beginning, as you've seen previously, of course avoiding the phrenic nerve. And this allows for this suture to be used somewhat dynamically as well, but more importantly to create a planar shelf. Sometimes it would only use at the P3 area, but oftentimes there's 2 stitches when slightly more involvement of the repair is required, or more analysis is required, particularly subvalvularly. So once this is placed, these can be manipulated quite easily and be dynamic along with the dual blade dynamic retractor. So now the analysis is complete. We can determine how best to repair. Chordal repair is possible. This likely might require more than one chord. I tend to favor focal resection when there's a significant flail, and chordal when you either just need a little bit of support or there's prolapse. So we're going to do a triangular resection again. because it does seem to be relatively focal, but slightly more than the previous case. You can see there's a decent anchor, but we do have significant fan chords. More to come on that. So we'll go ahead and finish the triangular resection. You can see the predominant myxomatous disease that I'm holding in the DeBakey. And then we'll complete the triangular resection to the opposing substantive chord. Of course, not overdoing the resection because that will expose the cleft between P1 and P2. Okay, so now the resection is complete. We'll pass that off and then take another look. We'll complete this down and then trim the leaflet as needed. But see here, we have another excellent chord that seems to be a better length. You can see those secondary and tertiary chords appear to be normal. The anchor chord noted here is a little loose and myxomatous, but the secondary chord looks a bit robust. So we'll come back to that in a moment, but I'll finish off the resection so that you have the two halves of the valve lining quite nicely and in parallel to each other as a foundational principle. Now, because the existing base chords are a little bit lax, I'm going to support them with what's called ipsilateral chordal transfer. Now, that's the chord groups that align with the appropriate papillary muscle. You never want to cross them. So this is the anterolateral papillary muscle and chord group, and I'm just reimplanting them with the same bite. We'll tie that 10 centimeter cardinal, squeeze the tail with my dual blade retractor as shown here, lifting it anteriorly. So now I've already supported the primary position with additional chords, even though I was somewhat confident in the existing chords, though it had a little bit of myxomatous disease. And now we'll do the valvuloplasty with a focus on it being quite precisely aligned, focused on the endocardial or surface of the leaflet. These are not always full thickness. They can be partial thickness as long as the leaflet anastomosis is smooth and homogeneous, and this will avoid small or trivial leaks after valve repair. I usually cut the previous stitch and use a tail as an anchor just to get that little extra exposure to stretch the tissues out so I can get that nice homogeneous alignment with the valvuloplasty. Then the final aspect is we'll bring the tail forward. I'll hold that through the working incision or working port and do a final stitch, usually a simple stitch that brings the final edges together to roll that final posterior leaflet together for optimal coaptation. The valve can then be tested, and this is the one benefit, or of many benefits of robotic surgery, is that you can be sure that you've completely repaired the valve before even placing the annuloplasty ring. This allows us to do a true-sized and fairly large flexible band, in this case a 38 millimeter band. These types of principles really have eliminated the use of small rings, and we feel that this allows for the maximum durability long-term without creating late stenosis. Following the principles we outlined earlier in the annuloplasty video, we've completed the annuloplasty in a true or slightly oversized band, since we know the valve was competent before, and you can see the nice depth of coaptation without residual regurgitation. And no stenosis, the mean gradient of 1. So I mentioned earlier But what about the patients that have predominantly prolapse and symptomatic mitral regurgitation, but without flail? So this is a 61-year-old patient who had exactly that. And you can see the papillary muscles are relatively healthy. There are many ways of doing Gore-Tex or polytetrafluoroethylene support cords. I'm going to show you a method that we use, and many surgeons use a similar double loop technique. But you can see that it's predominantly prolapse, but not flail. Of course, I've not overfilled the valve. This patient had a strongly positive stress echo showing severe mitral regurgitation. I tend to favor putting a simple loop without pledget, bringing one loop up through the valve, and then creating a second bite inside or medial to the first one, not tightening it. Do the same thing on the opposing side, and then creating a secondary loop. This allows for 2 neocords to be created with one suture, a fairly common technique. But I always get the question of sizing. So by creating the loop softly closed, making sure it goes in a line with other cord groups, it does give you the future opportunity for further tightening. So once the valve is quite secured, and I can place the largest possible ring, since we do have a fair amount of tissue to work with, in this case a 40 millimeter ring, the largest, or amongst the largest we have available, then we can tie the cord once it's been sized. I like to put a small cardinal bite just to get the suture tails minimized, and then place, in this case, a circumferential ring to complete the repair. There are many ways to use neocords, but this is a fairly straightforward and simple one that can create excellent coaptation and no residual mitral insufficiency in this patient. So these 3 cases now illustrate the fundamental standard techniques for mitral valve repair.
So now we've seen how to do relatively straightforward mitral valve repair, the most common solutions to the most common problem with type 2 primary degenerative mitral regurgitation. Sometimes patients don't have degenerative disease, but they have restrictive disease or calcific disease, when a mitral valve replacement is the best solution. Traditionally, that's done through a sternotomy, but join us in our next episode where we'll show you how to do robotic mitral valve replacement.